Good evening, everyone. I would like to invite Satyavan Sharma sir for giving a talk on myocardial viability. Does it make sense?
Good afternoon. When we were making the program, the topic which we initially decided was assessment of myocardial viability. But my good friend Akshay added a line to it, and I think that's where this topic has gone now. Does it make sense? Now let's look at. This was a patient admitted with me last week. Patient has an ejection fraction of around 15%, a prior history of inferior wall infarct, a stent being done, and there was a patient was having angina and dyspnea. The right coronary the stent was occluded and there were some collaterals. So one of my residents, I think he should be in the audience, he asked me, sir, do I take an appointment for doing MRI? I told, yes, take the appointment, but I don't know, after reading about what Akshay wanted me to do, I don't know whether we should do it or not. Now let me come to, when we call a ventricle as a healthy ventricle, the ventricle has a preserved ventricular wall thickness, contractile reserve, cell membrane integrity, active myocyte metabolism, and blood perfusion. So when all these things are normal, the ventricle is a normal ventricle. Now we have heard for a number of years terminologies called as a viable ventricle and a non-viable ventricle. And this is what has been a historical perspective. In ischemic cardiomyopathy or ischemic left ventricular dysfunction, these patients undergo viability testing for a long time. And I think it was in 1960s, late 60s, when Dr. Kanu Chatterjee, who has been from India, and Dr. Shahabuddin Rahmatullah did a huge amount of work on myocardial viability. And the terminology of a myocardium which is dysfunctional, a myocardium which is dead, or a myocardium which is hibernating, these all terminologies were used. And for ages, what we have been talking is a patient has a ventricle which is viable or non-viable. We know a ventricle which gets affected by myocardial infarction or ischemic dysfunction has a scar, a variable amount of myocardial which is dysfunctional but viable, and observational data which has been there for almost last 30 years have shown, or we have all believed, that when you revascularize these patients, there is, and if you document a substantial viability, the patient will improve. Now this is what have been two terminologies which we all have heard for years. One has been called as a myocardial stunning, and other is a myocardial hibernation. Myocardial stunning is, there is an acute abruption of the coronary flow, coronary occlusion as occurs in myocardial infarction, and after thrombolysis or PCI, when you improve the blood flow, the myocardial function improves. It will improve either within minutes, hours, or weeks, or days. There is another terminology, and it is myocardial hibernation, which, if you look at the earlier literature, have been that the myocardium is not dead, the myocardium is sleeping, or the myocardium is hibernating. And in myocardial hibernation, there is a reduction in the coronary blood flow, and the recovery of the coronary blood flow after revascularization will depend on the basal state of the chronic blood flow, and there may be recovery which may occur in weeks, months, years, and the degree of recovery may be variable. Now, this is what we have known as stunning, hibernation, advanced hibernation, and a myocardial infarction. And as I was telling, there are stages of viabilities, and these patients will have a different level of contractile reserve, glucose metabolism, extracellular volume, and depending on that will be chances of recovery. A myocardium which is stunned usually has a good contractile reserve, has a preserved glucose metabolism, and these patients usually there are 100% chances that there will be recovery of the ventricle. Whereas in early hibernation, there is contractile reserve preserved, there is glucose metabolism impairment, extracellular volume is increased, and these patients also improve within weeks. Advanced hibernation is somewhere in between, and in patients where there is an infarction or necrosis, there is no contractile reserve, the glucose metabolism is impaired, there is increase in the extracellular volume, and this is what we have called as the non-viable myocardium. Now there has been, over the years, last couple of years, we all have assessed myocardial viability by different methodologies. And there are almost hundreds of papers and some 150 meta-analyses. These are the 4 methods. Dobutamine is echocardiography, SPECT, PET, which assesses the glucose metabolism, SPECT, which assesses the membrane integrity, and the CMR, which is the current favorite, where we assess the SCAR as well as the gadolinium enhancement. Now, I will not go into which method is better, which method is this thing. We all have used all these things. And at the moment, what is more used is a cardiac MRI. There may be debate, PET is better or this is better. I'm not going to go into that. Why are the question which Akshay asked comes, are these 4 trials? And these 4 trials can be called as disruptive trials. They have smashed the whole concept of viability. And the trial which has been most important in this direction is the STITCH trial. A STITCH trial is a trial which has been comparison of surgery with medical treatment versus the medical treatment in ischemic cardiomyopathy. And this trial, when the data of STITCH trial came, there has been 2-year data, 5-year data, and now 10-year data is available. There was a lot of change in the concept. I'll just come to. And another trial is a REVIVE trial, which has come 2 years back. Now, this is the STITCH trial has a subarm of a viability studies. And what was shown was that there was a lot of conflict between the presence of viability and improvement of the patient, or absence of viability and non-improvement. So this STITCH trial gave a lot of controversial or different information than what we have known all these years. So let me tell you, this is the 10-year data of the STITCH trial viability. And in this viability arm, there were 2 groups. The viability assessments were done only in a small number of cases of the STITCH trial. 600 patients had the myocardial as the medical treatment, and medical treatment with CABG was in another 600. The viability in this was assessed by the SPECT and by dobutamine. And what the result of the trial was, although this trial showed that at the end of 10 years, there was benefits of the CABG as compared to medical treatment. However, the important information which came and which may have bearing on change of concept was that whether the myocardium was viable or myocardium was not viable, there was no difference in the mortality. Both the groups, the medical treatment group and the CABG group, had high mortality, but this was one information that viability had no bearing. And this was another trial, the REVIVE trial, which came 2 years back. In this trial, patients with reduced ejection fraction below 35%, viability being assessed by dobutamine stress, MRI, SPECT, PET, and they were randomized to 2 groups, coronary intervention and the medical treatment. And this trial also showed that viability has no there is no benefit of PCI in those patients where there is viability and this is the comparison of these two trials, the STITCH trial and REVIVE trial. These two trials have some similarity. The similarity is that both these trials challenge the concept of viability. That even if you are having a viability, there may not be improvement. The STITCH trial, as I mentioned, is a surgical trial. REVIVE trial is a PCI trial. The population in these have been little different. More older group in the STITCH trial, little younger group, more older group in the REVIVE trial. And both these trials have shown the same outcome. So the questions which arise after these is, should we refrain from viability testing? Is LVEF a valid surrogate, and what should be the new paradigm? We have known for years that the benefit of revascularization is because of the recovery of the left ventricular ejection fraction. But these two trials say that that is not the mechanism, because in a STITCH trial, the improvement in ejection fraction was just 2%. So what is now coming is that the benefit is related to protection of the remaining viable myocardium from future MI rather than the dysfunctional MI. And this is a meta-analysis of non-viable revascularization in ischemic cardiomyopathy, non-viable myocardium, and this shows that even in non-viable myocardium, there can be improvement. So the take-home message is, all patients of ischemic cardiomyopathy benefit from GDMT. Viable myocardium is not a single entity, and whether we should do testing or abandon it, I think this answer will come in future, but these trials have shaken the concept of the viability. Thank you very much.